Hello and welcome to this webinar that's been hosted by Pallium Canada. And today's webinar comes with support of Boehringer Ingelheim and their Bridging Hope program. We're very grateful for that. Over the last few weeks, we've been broadcasting various webinars related to palliative care in the COVID-19 pandemic. They've covered different topics, everything from PPE and the use of PPE to medication, symptom management, shortness of breath management, system reorganization. Today's, I think, is extremely important because it speaks directly to us as caregivers, no matter what profession we're in, no matter what setting of care we're in. Today's webinar is entitled Role of Grief and Bereavement in the Care of Healthcare Providers and Their Families During COVID-19. In essence, it's going to look at the impact on us as healthcare professionals. We're all touched in one or other way. Some of us right in the front lines of care, our colleagues who are working in the ICU, in the emergency departments, in the long-term care facilities and nursing homes. But it's a ripple effect because it has effect right across the system. Some of us are working in hospices or palliative care units or other hospital units or at home. And what we are seeing is the impact of isolation, of patients spending their last days of their journeys alone with very little contact with loved ones and the support of loved ones and friends. And it's very painful for families and patients, but it's also painful for the healthcare professionals. So today we've got a fantastic group of panelists to help us explore this topic, and I'll come to introduce them very shortly. I'm reminded of two quotes. And the first one is from Eric Cassell, the scholar on the nature of suffering. In his book, The Healer's Art, he reiterates the mighty struggle of the doctor, and I will add here the nurse, the social worker, the chaplain, etc., the psychologist, is with death. To the patient, the image of the doctor, the healthcare professional, is that they have already struggled with death often and have won. And that's not always the case. The second quote comes from Leonard Cohen, the Canadian poet and singer. In A Message of Hope in Darkness, he wrote in his poem and song Anthem, "Ring the bells that still can ring. Forget your perfect offering. There is a crack in everything. That's how the light gets in." So with that in mind, just remind you, so some housekeeping. First of all, the format is going to be in three parts. The first part, we're going to be asking Professor Carlos Centeno, who's been working in the front lines of the COVID epidemic in a country that's been devastated by it, namely Spain. And Carlos is going to be sharing his personal journey, his personal experience. And we thank Carlos for doing this, because I know it will probably activate some memories for you, some very, very vivid memories. In part two, we're going to be getting overviews from the three panelists that include psychologists and psychiatrists who are experts in the field of grief and bereavement, both in the care of patients and families and healthcare professionals. And then in the third part, we'll be opening up to questions and answers and comments from participants. Now, your microphones are muted. There are several hundred of people signed on right now. So we're going to ask you, please, to, if you look at the bottom of your screen, you'll see a bar that has got a Q&A function. So please do submit any comments or questions you have using that Q&A function. Please do not use the chat function. It's going to be easier for us to capture the Q&A function and to respond to it. We're going to try our best to cover as many of the questions as possible, but you can imagine with hundreds of people signed on, we might not be able to address everyone's questions or queries or insights. So we're going to capture that with the Q&A. We'll try to respond offline to some of those questions. And if there's a lot of interest, we may actually follow this webinar up with another webinar to explore the topic further. The session is being recorded, and at the end of the session, you'll be receiving a link to that recording within 24 to 48 hours. Please do share that link as well with colleagues who weren't able to be with us today. I'm José Pereira. I'm Professor and Director of the Division of Palliative Care in the Department of Family Medicine at McMaster University in Hamilton, Canada, and I'm also Scientific Officer of Pallium Canada. I'm going to introduce you now, or ask our panelists to introduce themselves. Mary, can we start with you, please?
Thank you. I'm Mary Elliott, and I'm a psychiatrist at Princess Margaret Cancer Center and an assistant professor at the University of Toronto. I have an interest in mindfulness. I'm trained in MBSR, MBCT, MSc, but I've also gone on to create a number of interventions for healthcare providers: compassion, presence, and resilience training, CPRT, and BRIGHT, building resilience within institutions together with employees. So this topic is near and dear to my heart. And of course it became near and dear because working in this field for 30 years, I found that there were a lot of squatters in my heart of people who I hadn't grieved. And so I think it's really with a lot of foresight that José has brought this panel together, and I'm thrilled to be a part of it.
Hello, I'm Carlos Centeno. I'm palliative care doctor, living and working in Spain, but trained in Canada 20 years ago, and in Edmonton, and later on in Ottawa too. Also, I am researcher. I am the chair of a group of people that is working in palliative care research with the focus of humanities and social science. It's the Atlantis research team that is located in the University of Navarra in Pamplona in Spain.
Gary?
Hi, I'm Gary Rodin. I'm glad to be a colleague of Mary's. I'm a professor of psychiatry at the University of Toronto and the Princess Margaret Cancer Center. And my clinical and research focus has been on the psychological and social dimensions of life-threatening and advanced disease, particularly cancer, and on psychological interventions to help this population, and locally, nationally, and globally. And on the whole circle that are involved, the patients, the family, and the healthcare providers. So it's very pleased also to be involved in this kind of discussion today.
I'm Peter Barnes. I coordinate bereavement services with Eastern Health, the farthest east health authority in Canada. And in this work that I do, I have a passion for complicated grief. And I find that out of that, I've grown in done training, and now I'm a certified somatic experiencing practitioner. I find that grief and trauma go together, and it needs to be addressing both in our work. And so I bring that perspective to this session, and I'm very pleased to be a part of it. Thank you.
Thank you very much. So last few quick things. Declaration of conflicts. Pallium Canada is a non-profit organization. Over the years, we've received most of our funding from Health Canada. These series of webinars are being supported by an unconditional education grant from Boehringer Ingelheim. I am paid as a scientific officer for Pallium Canada, and our other panelists have got no conflicts of interest to declare. In terms of the learning objectives, very quickly, we are hoping that at the end of the session, you'll be able to reflect on your own and others' experiences of providing care in a pandemic and how it affects us personally and collectively. Adapt perhaps the bereavement care approach to grief we experience, and explore personal change as a healing presence to self and others. And identify tools that best help us to cope with traumatic loss. But this is a somewhat open format, so let's just see how it goes. Handing you over now to Carlos. Thank you.
Hello. As I already told you, I'm living and working in Spain. I work in one university hospital that is at the north of Spain, where I lead the palliative care team in a university hospital. It's a very small team with around 3 doctors and 3 nurses, psychologists, and some others in training. 4 weeks ago, or 5 weeks ago, I was at my home through the weekend, or just a few days before the weekend. I received one call from the director of another hospital that is in Madrid. That hospital is it's a kind of twin hospital of the hospital, the University Hospital of Pamplona. The name is the same, Clínica Universidad de Navarra in Madrid. It's a very small one and very new. It's a hospital with around 60 beds, 60, but high technology, very new, private hospital, very specialized for difficult patients mainly. The call of the director of that hospital was in tremor, was in hurry. Carlos, we need you, we need your help. Tell me, what happened? I knew well that doctor, what is happening? You know, because the crisis, we have strong problems in the hospital. We opened the hospital for the national health system. Immediately, dozens of patients came into the hospital because that we cannot attend properly to that patient in this very short time. Some of the patients die in very difficult situation. It was very bad for that patient, but also for the team. We are devastated for that situation. Can you help us in some way? What do you suggest? What do you do? And then I feel that I need to offer myself, but not offer my thoughts, not offer a clear idea of what they can do, because I know the hospital, I know the people that is working there. That I feel at that moment is I need to offer myself. It's a kind of compassion heart that all palliative care doctors we have that start to deep, very, very strong. So I offer myself, you know, doctor, that can I do is to go and see and suggest to you something. And that was start my journey through being a doctor in palliative care, living comfortable in my university hospital, and to be in the middle of the nightmare of the COVID crisis, to that tsunami that was happening in Madrid 5 weeks ago. So I take my car and I went to Madrid the next day, very early in the morning. Through the journey to Madrid, I start to think what I need to know. I need to know more about COVID crisis. I need to understand what is happening with that patient. And in the car, I did some calls to some colleagues in Madrid that are working in palliative care, in big hospitals, in the university hospitals of La Paz in Madrid and Laguna Hospital. Tell me something about the patient. How is that patient? Because until that moment, I didn't meet one patient with coronavirus. So I need to understand the disease. I need to understand something about that. So I received the advice of my colleagues. Immediately, I realized that I need some continuous infusion pumps, that we will need midazolam, that we will need quick guides for the doctors, because my mission in Madrid will be to help in organize the situation. When I arrived to the hospital, I find a hospital in crisis because the hospital was preparing to double the capacity that day. No 50 beds, but 100 beds. And immediately I try to understand something. I present myself, I introduce myself to the person that was in charge of that organization. And he told me that could be helpful for you, could be to attend the clinical session that we will have in 50 minutes. Okay, I will attend that session. And since that moment, I start to attend every day 2 clinical sessions about all the patient that was in one of the main settings, in one of the main rooms. So in that way, I start to experience some kind of confusion. What is happening here? What is needed here? What is the role of palliative care here? Because the most important that I understand that is happening is we need to organize better the things. We need medication, we need doctors, we need people in the emergency room, we need nurses at the units. That's important. Palliative care now is not important probably. What is my role here? What I'm doing here? A kind of intellectual confusion. And I realized also that I didn't know about that patient. I didn't know about the disease, the clinical course of that disease. I need to know more and more. And through the first 2 days, I understood more and more and more about the COVID crisis. And I experienced in the very first moments, from the intellectual confusion, I went to the intellectual fruition, because understanding more and more of the disease and the physiopathology of the disease and the way of the monitor the patient, the dozens of patients that were there, I experienced the same feeling that I experienced when I went a student of medicine years ago in the Faculty of Medicine, learning new things. My experience was that I'm learning a lot. I understand the new things. This is one enrichment, a personal enrichment to me. And in a moment, in very short time, but that I'm telling you is only a few days, in the second day, I experienced this kind of enjoyment, of fruition, intellectual fruition, because I were understanding more and more and more the situation and the disease. But at the same time of the confusion and the enjoyment, I feel the fear, because the fear was there. People was fearing what is happening here, fearing of contamination, of to get the disease. That was my same sensation. Is immediately you have to be protected with gloves and with a mask, and you cannot touch, and you have to take distance for the people. But all people was this kind of fear, and many people are reminding you, please don't touch, please far from me. So the fear is there. But at the time of experience fear, I experience also courage. I experienced that is worth to do. It is dangerous, but it's important. I experience also the fear of the crash of the health system, because in Madrid, in those days, in Madrid, we are in some hospital also in shock, because the levels of the health system was under the limits, just in the limits. So the fear was not only for the contamination, but the fears of the collapse of the systems. But I fear that is worth to do. At the same time, looking around, you can see many others that are with you, with the compassion heart in action, without fear to be close to the problem. People that dedicate to other specialization, for instance, the plastic surgeon was in the COVID plant in setting, and the specialist of radiotherapy is in the emergency room, organizing the emergency room. And you feel that you are part of this movement, of this health movement that is people that wants to be close to the suffering, trying to help. And you experience that situation as an honor. It's not important that I'm doing. That is important is that I am part of this kind of tsunami of compassion that is happening in the health system. The next day was days working in the protocols, because we need to develop protocols, proceedings of many things, of treatment of dyspnea, of sedation, of the visit of the relatives, or how manage the body in that situation, because all of that was new. We work hundreds or dozens of hours in few days. And at the same time, I was talking with many people, with the chaplain, with the nurses, with the specialists in infections, with the pneumologists, with trying to develop that protocols in the best way. Sometimes I experience again that palliative care was not important in the crisis, and I understood that it's true, that it's important is to cure the people with the infection, but sometimes you feel ignored in that movement, or you feel unneeded, and sometimes you are waiting hours to have a conversation with one of the doctors or one of the chief of the emergency room, and then sometimes you feel bad. You feel that as palliative care doesn't matter to anyone. But through that combination of feelings, in a moment, the light arrived. The light arrived with a solution for the hospital. Understanding the disease, understanding the hospital, understanding the situation of the specialist, you can offer one solution. Why not to put a palliative care support team inside the units? A kind of support COVID team, we call. We don't use the word palliative care in that situation. Supportive care team in the units. So I choose one of the oncologists that was trained already in palliative care, and also one nurse that was training under us in Pamplona, in the other hospital that was there, and put these two persons together. And then we designed the way to work inside the units. And we offered that solution to the direction of the hospital. And they approved the solution. And then they decide this is the way that we are working with the patients that are less, with less possibilities to survive. In the moment that we decide the order of no reanimation, that patient will be in your hands. You will manage that patient. That was the solution. All was happy with that solution. And since that moment, the nurse and the doctor start to attend the first patient in the units. So the first patient was seen by the three together, because we realized we have the plan going inside the unit, dressed properly. We realized that the other two patients that we want to see was unable to receive us in that moment, because one of them was very bad in that moment, and the other one was receiving some kind of examination. So the three went to one room to visit one patient. That patient was not very healthy. That patient was with dementia and with delirium at the time. Then we cannot connect with the patient. But that patient had at his side his wife. His wife was there because they get the disease when they were inside the hospital. So his wife decided to be with her husband inside the COVID room. So we start to attend that person, that wife, that woman. We start to talk in the simple way that one palliative care physician usually do. It was very easy conversation. How are you? How do you feel? Did you receive information today? How are you seeing your husband? Very easy things. And that person, receiving our conversation, became almost happy in that situation where her husband was almost dying. And you know, in that moment, I experienced the power of palliative care. I experienced the power of the healing presence of a palliative care doctor attending a patient. That was the day 4. The day 8, the team was working very well. The people was happy with the team. And that I experienced is I was very, very, very tired. I went to my city, that was 2 hours driving from that place. I went to my city and I feel that I need to rest. I was much more exhausted than I thought. I need to rest and I need 3 days without to do nothing. Unable to think, unable to feel, unable to structure my brain. But after 3 days and coming back to my hospital, my thought was, this is the COVID crisis. What palliative care can give to that situation? First, palliative care has to give his arm, his workforce capacity. The COVID crisis need only a small amount of palliative care. The COVID crisis need enormous workforce capacity because in Madrid, in my city too, in Pamplona, the crisis is so high, so big, that need people working and working. Palliative care has to offer his workforce capacity to the COVID crisis in first position. And then being inside the COVID crisis, palliative care can offer his expertise, that is that healing presence, that compassion work, compassive work, this capacity of to do humanization in the health system. This is the role that I understood that is more important for palliative care. It was only 1 week of work with all these feelings around between the compassion and the intellectual confusion, but also with intellectual enjoyment and fruition. I experienced personal enrichment and honor to be part of that movement. Sometimes I feel ignored, I feel bad, but at the same time, I experience again that palliative care is worth being there with his healing presence. That's all. Thank you very much.
Carlos, thank you. Thank you so much. I'm sure if there was a virtual sound meter, it would be registering 0. That was profound. I'm going to hand over now to Gary, and then Mary, and then Peter to fill in additional thoughts. Stephanie, could I ask you to advance the slide?
Spain being, one of the very first countries to suffer so much from COVID. And when we think about the well-being of the caregivers, I think we've heard a lot from Carlos. And there's so many things that are overwhelming. The enormity of the losses. We've now seen 250,000 deaths worldwide. Last figures I saw were 21,000 in Spain. New York City alone had 10,000. And a colleague of mine in New York yesterday told me that at one hospital, at the 4 hospitals of NYU, there's currently 1,100 people in the ICU at NYU hospitals, which is just enormous. Doctors are operating in this context, isolated to some extent from their colleagues, from their families. There was a lot of ambiguity and confusion early on about what they should be doing, what was adequate personal protection, I think, which caused a lot of distress. People were working long hours. I think the fear of personal risk is great. And as we heard from one of the people participating today already, what about the fear of contaminating one's family, the harm that one would spread to one's family? And also moral distress, which maybe this doctor who was the first, one of the first to understand that this virus was causing damage and to report it. And he was a kind of whistleblower who was censured, but he, in the end, became very ill. And I think these moral questions and moral distress have arisen subsequently also in decisions about who should get care, who should be admitted to an ICU, and who should get treatment for their comorbid medical conditions. All of these take a toll on healthcare providers. We're going to hear from Peter Barnes about grief, but really there's, as Carlos has said, there's a whole range of emotions that people feel. Fear, anxiety, sadness, depression. We begin to see syndromes of burnout as this becomes more prolonged. People in this context are at high risk for acute stress disorder and its more prolonged form, PTSD. These are associated with a high degree of physical and psychological morbidity. And all of the caregivers we know from previous pandemics, from people exposed to trauma directly or vicariously, they're high risk for all of these disorders. So how do people manage it, and how can we help? And there's an interesting theoretical body and experimental body of literature that we've been drawing on called terror management theory. And terror management theory says that there's 3 essential things that help people manage terror, and death anxiety is considered the most fundamental of terrors. And one is self-worth, and of course, the sense of self that we have going into this matters, but anything that the environment can do to enhance the self-worth of people providing this care, the sense of meaning from what they're doing, and also the sense of support, the sense of connection to others. And a lot of our interventions, I think, and we're going to hear next from Mary Elliott about a systematic approach, have to do with supporting these things, supporting the value that the healthcare providers provide, the meaning that they're providing to the community, the value, and that we're all in it together. And we've seen that at the level of peers, of physicians, and of the public. And this is from the UK. These are people in their apartment buildings, as in many countries in the world, who are cheering the healthcare providers. And I think this connection, this sense of value that's ascribed to people, I think has great meaning. And we know that we should begin to protect people early. I mentioned some of the complications that we see, but I think one of the gratifying things that we've seen is that people have recognized this now early on, that support provided early from peers, from supervisors, the cohesion of teams that we're directly working with and more broadly is extremely important. Preparing people for the kind of moral decisions we're making about those kind of issues about who can be admitted to an ICU, who can get treatment for their disease. I think clear communication has been very important, and I think we've seen some frustration in healthcare providers when they were given what they consider false reassurance, particularly about certain personal protective equipment. I think that's caused a lot of confusion and distress. Self-care is important, self-monitoring of distress. Most of these interventions will help people from needing more specialized mental health referral, but that's something we need to consider and have available Certainly adequate personal protection is extremely important, both for physical well-being and psychological well-being. And we know the risks are prolonged. They don't end at the end of a shift or at the end of a week or month. So we need to think about what kind of aftercare we're going to provide for the healthcare workers who've been working in this environment. So José, and all that's a kind of brief overview of what we can do. And now we're going to hear Mary talk about, I think, a more systematic approach.
Thank you, Carlos, and thank you, Gary. This is really challenging. We're just going through such a tough time. We're all going through a tough time. And my wish for myself and for all of you is that you can do things to make space for yourself, to pause and have a cup of tea, to just even be with your own breath or feel your feet on the ground or look out a window and see the wider world. And in saying those three things, that's a self-compassion practice. I named that this is tough. I named that we're all going through this. It's a universal, it's not just me, it's universal. And that I offered myself some sort of sense of nourishment. And I bring this up because I have a hand on my heart from having listened to Carlos's beautiful story. Beautiful in its poignancy, in its humanity, and also how in the struggle and coming to this place of meaning and altruism and a sense of accomplishment and efficacy, beautiful for that reason, not beautiful in that there was a lot of suffering along the way. Early on in the Toronto aspect of preparing for COVID and responding to COVID, we had calls from teams of people where there were some concerns that there were unexpected exposure risks. And it became very clear to me, these calls came in late at night, and it became clear to me that we had to act, and we had to act in a way that could be widespread through our hospital, and that we needed a system where we could aim to foster a healthy, maintain and foster a healthy workforce throughout and beyond the pandemic. And our goal is really, with this program we created called CREATE, Compassion, Resilience, and Team Building. Thank you, Gary, for the name. It's a way of supporting teams at Princess Margaret Cancer Center. And really our aim is to hope to prevent stress from becoming distress. I don't need to review for you, but we recognized and looked at the literature that was coming out of China about the novel stressors and the extraordinarily high rates of depression, anxiety, sense of trauma, insomnia, and moral distress. And we also recognized that it was going to be really important to make people feel safe psychologically, as Gary was alluding to, and to enhance psychological safety, the team sense, the hospital sense that we're safe. And there, as Gary mentioned, it's been a challenge because of limitations in availability of PPE or threat thereof, limitations around equipment, limitations around testing capacity, etc., and even human resource. So we really knew we had to go in on this basis. And we wanted to have this team-based approach where we could triage individuals as needed, and we could provide resources and link people to resources on an individual basis. Our consultants who participate in this program, and we have 13 involved in linking into this, in being designated to a manager, a clinical manager in the hospital, and then fan out. They're responsible for all the teams that come under that manager. Consultants aligned to teams, to managers they had some familiarity with. And we were able to build on previous work, such as the CPRT program, compassion presence and resilience training for healthcare providers, as well as the BRIGHT program that had been rolled out 2 years prior to the pandemic, which is building resilience within institutions together with employees. Next slide, I think, yeah. So we created this program in March, and shout out to Dr. Madeline Lee, who is the co-lead of this program with me. We created it together. Early in April, if you haven't seen it, there's this wonderful article by Schanefeld and his group where they interviewed 69 healthcare providers the first week of the pandemic in their city in California. They came to some understanding around themes that were important, and they or requests on the basis of these interviews, requests from healthcare providers of what they need. And it got conceptualized as hear me, protect me, prepare me, support me, and care for me. And Carlos referred to all of these areas. But what I would say is a lot of them are focused on the organization. And what we've found is that, and leadership, which is absolutely vital. Can we go to the next slide? But what we found to be so different with this pandemic compared to SARS and compared to the literature on burnout is that the individual psychological response, the individual needs were much higher. Typically, when you look at the burnout literature, they say that 80% of burnout is related to systems and organization and 20% individual. And we were finding that, and maybe it's because we learned from China, from Italy, from Spain, some of these areas that we had to attend to in terms of communication, preparing people, protecting people, preparing people for redeployment, and supporting people, and also caring for people who were exposed and became infected. What we were really seeing is this need for feeling psychologically safe. Could I have the next slide, please? So in this program, basically, we've been it's a proactive, preventative model, pairs managers with a supportive care psychosocial professional, and we use a coaching model. The program is tailored, so it's personalized to the particular team contexts and stressors. It's pragmatic. We really use a psychological first aid approach to promote safety, calm, efficacy, connectedness, and hope. It's based in the polyvagal theory of social engagement systems where, you know, we've all been disconnected to a certain extent from physical distancing. So people are out of their elements. So they've moved from that optimal balance that is, which is emblematic of the ventral vagal system into like the sympathetic nervous system, fight, flight, freeze, and sometimes even folding. And so it's really important for us, and we can do this with quick interventions around communication, focusing on connection, focusing on short practices, breathing techniques, practices out of our BRIGHT program to bring people back into a more optimal zone, along with this the real efficacy you can get out of team cohesion. We do this through pre-existing meetings, team huddles. We have touch bases, and we have some formal groups. We have these short practices that we use with people, and we really have taken on a big advocacy role. as well as we plan interventions for down the road. And Carlos beautifully talked about all of these elements of moral distress that, you know, we've been forced to work, and this is what we're hearing from our teams, you know, this shift from a culture of care to a culture that's warlike, and trying to move back to the compassion, to the care. And I saw this in action when we had a COVID patient who was sick and also had metastatic cancer. And all of the fears and worries of the nurses dissolved when they put on their equipment, and their only question is, how will the patient know I care about them? How can I show my compassion? And we developed a little module, or we had a little discussion around that. You know, this after the fact, we know that people who have suffered from moral distress are more at risk for trauma, are more at risk for complicated grief. I loved when Carlos said, tell me about that patient. He meant medically, but also we can't lose the person in this. And I think with his big heart, he meant compassionately, who is this person who I'm about to treat? And this is part of the moral distress, that we're so overloaded in the system right now that we've had to shift from best practice to best practice under pandemic conditions. So what our team tries to do is insert the compassion, the humanity back into how our staff can be practicing, so there's a little less moral distress. But they still are forced to practice in a way, you know, usually we have some sense of autonomy in how we practice, and now we're being told through triage and rationing resource about how we can practice and how much time we have to spend with people. So there is a lot that could be said. It's not surprising to me that Carlos, at the end of the 8th day, felt the sense of collapse. We're also, or exhaustion, as married with this sense of accomplishment and joy that he was able to bring palliative care to people. I think that's absolutely beautiful. And what we're trying to do is help people move out of that sympathetic drive where the adrenaline is eventually just going to wear out, and to come back to base, to reset and restore throughout their work days. So I think I'm going to end there. I would love to talk about the model more another time, but I really want to move this along to Peter, who's going to talk about grief, and I invite questions as well.
Thanks, Mary. I could spend a lot of time just kind of connecting all things together. My first slide, please, Stephanie. What I want to do here is just to put emphasis on what has been said already, because it's been just so valuable. The whole idea of a grief process, the whole idea that in this time, people are being challenged by just the sense of loss. We call it anticipatory loss. People are just almost drowning sometimes in that loss, and the horror that people feel on the front lines by our healthcare practitioners or providers. So the idea that grief is a process, and the way that Carlos represented it so well was the emphasis on the gentleness, and that came across, including his need for 3 days to unwind, and Carlos also made reference to healing presence. And it's interesting, we can't learn healing presence, we have to be healing presence. I want to stress that, and that's what Carlos exhibited for us. The idea of transforming grief pain, and that's what I felt happened, and I think was reflected in certainly in what Mary was just saying, and also in what Carlos said in terms of that time with that woman with her husband dying. There was an acknowledgement, and that that grief pain was transformed, and she smiled and appeared happy. Like it's kind of countercultural or counterintuitive, and yet it was real. And so that's the idea of transforming the grief pain into something that may be heartwarming or a felt shift. I think that could be expressed there as well, and certainly expressed, as Mary said, in the body changes, being in that moment, in that mindfulness, to be aware and to feel that in your body. Grounded in this transformation for grief pain is connection, and we do that. Like, we need connections, we need community, and I want to draw your attention, Stephanie, if you could move to the, no, not this one, the next one, please. Yeah, this one here. It's called dual process grief. And the whole idea that in grieving, in anticipatory grief and grief after the death or multiple deaths of people we've been working with, the idea of loss orientation and restoration orientation. We call this a pendulum. So you touch on one and then you move away. And that's the idea that Carlos needed, that 3 days away, is that he was so engulfed in the hospital situation. That's what we call the loss orientation. But then he needed restoration orientation. So the idea of having balance in our lives is so important. And I want to draw to your attention, Stephanie, if you could go back to the original slide I have there, this one here, yeah. The idea of a wounded healer, to acknowledge our vulnerability, to acknowledge our humanity, and to be patient. These are so important. And I want to kind of pull it all together with an initiative by Pallium Canada called Compassionate Communities. And I think that just the same as we look at palliative care and call it a palliative care approach, and that's what Carlos embraced when he was in the hospital in Madrid. He put into effect a palliative care approach. And similarly, I think that we need to consider how do we create and encourage compassionate communities approach to our care, and not just in times of crisis like this pandemic, but at all times as well. So I think on the other slides that I have there are primarily quotes, and if you can move further, yeah, there, and that's a little bit of information, but it's available on the website. So thank you very much.
Fantastic. Thank you so much, Peter. Mary, I think you had an extra or something else to add?
I was also reflecting when Carlos, you were speaking about the power of reflection. And what I'm finding is that our team, we have debriefs, but we also tend to be writing emails back and forth, which serve as mini debriefs. So in one, I wrote to someone who was working with a very psychotic patient who had COVID with a combination of psychosis from schizophrenia and from likely delirium, very ill with COVID. And I said, we're really stretching our skills as psychiatrists and our hearts as human beings. And that came out of just listening to bearing witness to his experience, 11 o'clock at night in an email. Carlos, I think that whether you had done this prior to preparing this talk or not, I think just going through what your experience has been is so powerful in terms of the reflection. And I just wanted to highlight that because it moves the story from one of fear and challenge to one of optimism and hope. So I really appreciated that.
Thank you. I see there is a question from an attendee, and the question is denial also a part of palliative care? Would anyone like to jump in on that?
when I think of denial, I try to reframe that, and I think Carlos spoke very well of making meaning of our situations, and I feel a more compassionate. I feel that denial is a judgment, whereas if we reframe that to understand it from a more compassionate perspective, it gives us greater understanding. Like when people say, "Oh, he or she is in denial," well, I say they're not quite there. They may be in shock. They may be from, when we look at William Worden's 4 Tasks of Mourning, he talks about the acceptance, but we accept it in our mind first. And eventually there's an acceptance in the heart, and it's all together. It's so important to wait for that. So people may not be in denial. They may be just in, when we look at it from the nervous system, as Mary did a few moments ago, you see that people move into a freeze zone, and they're not in denial, they're frozen. So that we have to slowly encourage them, and this is where the pendulation comes in, as far as I'm concerned. When we work with people that are traumatized, we give them a chance to touch on the trauma and on the fear and on the hopelessness or whatever it is, and then we help them move away to reorient. And I think that's a more compassionate way of looking at it. Thank you.
Thank you very much. Folks, I'm looking at the time. I know we're almost up. And I was looking at the questions. I think, people are probably were mesmerized by this. And I'd invite participants, if you think that you'd like to follow this webinar up with another one where we can explore these concepts further, please do let us know so we can get a sense of whether that is needed. I suspect it is. For me, it was one of the most remarkable workshops or presentations that I've ever attended. I must say it touched me personally in many areas, as a healthcare professional, as a friend of some of you, and to hear your experiences, your insights, your wisdom. And I'm sure everyone else listening in felt the same way. So I really want to thank you all for your fantastic contributions, for the generosity of your time and the generosity of sharing your wisdom and your insight, and deep from the heart and deep from the mind, as Dame Cicely Saunders would say. So let's wrap up again to remind everyone that this session has been recorded, so it will be made available. You'll get a link, but if you go to the website, pallium.ca website, there'll be links to all the recordings of the different webinars. I'd like to thank as well the Pallium team that helps organize this, and very importantly to all of you across the country. I want to thank you for the amazing work that you're all doing. Thank you for being part of this. What we're learning here is a collective effort of learning from each other and sharing our experiences and insights. So with that, I'd like to thank you all and bid you all